Newborn, part 2. So now we're going to talk a little bit about bilirubin and physiological jaundice. Coming into third semester, you know a little bit about jaundice. You know that usually it's that yellowish skin color of the skin and sclera due to elevated serum levels of bilirubin or hyperbilirubinemia. Interesting enough, remember we talked about how the newborn has all those extra RBCs in utero because it's less efficient at O2 exchange. Well, now when the baby is born, it no longer needs this higher level of red blood cells. And what happens is it begins to break up some of these red blood cells, and the byproduct is bilirubin. The liver now is responsible for the conjugation of bilirubin, and it results in the breakdown of the red blood cells. So the red blood cells are no longer needed, they're breaking down, and now we've got all this bilirubin, and now the baby gets hyperbilirubinemia, which is excessive. And how does the baby get rid of this bilirubin? Well, it excretes it through the stools. Well, interesting enough, the newborn is born with a sterile gut, and now and hasn't normally had its first bowel movement, which is the meconium. Sometimes in utero it does, and that's what we call McStain for the spontaneous rupture of membranes. But most babies will have their first bowel movement within that first day, sometimes within probably the first 4 hours of life. So now the body is responsible for breaking down the byproducts the liver is. Well, what happens is babies they've got all these RBCs to break up, and they've got all this extra bilirubin, and they need to eat and feed to get rid of the excessive bilirubin in their stool. Now, those that are bottle fed probably will have more feedings because remember we just have the colostrum for the breastfed babies. But so sometimes the breastfed baby is a little bit more prone for physiological jaundice or the non-pathological jaundice. But we know that if we have the mom breastfeed within the first hour of life and it stimulates the milk production and gets the baby's bowels moving, that it decreases the chance. But when I talk about jaundice in the newborn, it occurs in 60% of newborns and 80% of preterm infants. And so it's significant to talk about when I talk about some of the things that we look for in infants that are not the norm and that some of the things that we have to watch out for. This is probably one of the biggest ones. Most of the time, this jaundice is going to resolve without treatment. We know that breastfeeding occurs, jaundice occurs in the first few days from just a lack of calories. So we'll be watching those. And that's why we make sure that the babies are eating and every 2 to 3 hours. If the baby does get jaundice and it's not treated and the levels get high, it can turn to a pathological condition that can cause neurological damage to the infants. Therefore, we pay close attention to this newborn jaundice. There's 2 types of jaundice. There's one type of jaundice that's the pathological jaundice at birth, and that usually is going to occur within the first 24 hours of birth, and it can lead to neurotoxicity. Now, the one that we're talking about usually is the newborn jaundice that's due to lack of calories or the excess of RBCs not being broken down, and that's going to occur after 24 hours. So the pathological jaundice in the first 24 hours is a little bit different. We're going to concentrate more on the one that occurs after 24 hours due to the breakdown of the red blood cells. Now, granted, pathological jaundice is any high level of bilirubin that exceeds probably 15 milligrams. And so this one that occurs in the first 24 hours, you're going to catch really early. The other, which is 60-80% of the newborns, you're going to catch after 24 hours. So this is the pathological jaundice of the first 24 hours is a little bit less common than the one that we're going to talk about with the newborn jaundice that occurs after 24 hours. But remember, if any jaundice is left untreated, that it can turn to pathological. So hyperbilirubinemia is prevention is best, and how do we prevent it? By breastfeeding within the first hour of life. Sometimes we have to treat it, and when we treat it with phototherapy. So it's interesting. So when we want to prevent and we want to treat it early, what happens in the hospital is We know that 60% of newborns and 80% of preemies have this jaundice after 24 hours. So when the baby is 24 hours old, we do a non-invasive transcutaneous bilirubin level. And most of the time, we're just going to get it off the forehead. It's non-invasive. And if that level is high, then we would have to go and get a blood blood sample. And usually we would just prick the heel for a drop of blood and send it to the lab. And that would tell us the serum level. And that's what we treat, is the serum level is what we're looking at more closely. The transcutaneous one is more of a screening tool. So if it's okay, it's fine. But if it's high, then we would get the serum level of the bilirubin. And that's the one that we would treat if it was high with phototherapy. I could give you a level on what's normal and not, but it's really a graph depending on the age of the baby when we treat. But normally, if we get one between 10 and 15, that's pretty high, and we'll probably treat with phototherapy. When we treat with phototherapy, we put the baby under the lights, or we put him in a bilirubin blanket that has the lights. So it's really important to monitor baby's temperature, make sure the baby's eating with adequate nutrition. So if the baby's fine, other than a little bit of jaundice, we keep babies with mom so that they can be keyed in on feeding cues. So we feed babies before they start crying with hunger. When a baby starts sucking, making sucking noises, or putting their hands in their mouth, looking for something to eat, we encourage moms to feed them at those signs of feeding cues, early feeding cues. Crying is a late one, and by then, if you wait too long and they're crying and they're upset, it's harder to settle down and to get them to breastfeed. So we want them adequate hydrated, which means breast milk, or feed them on a regular schedule with formula. Babies do not need any extra water or anything. All they need is breast milk the first 4 to 6 months of life. We need to monitor the stools, and that's because, remember, they're excreting the bilirubin through the stools. And we keep them on a regular feeding schedule to make sure that they are excreting their bilirubin. Again, there's decreased chances of hyperbilirubinemia if the baby is breastfed in the first hour of life. Sometimes babies with bruising will release more bilirubin into the system. So, instance, if they had forceps delivery or vacuum extraction that caused any kind of bruising or traumatic delivery, we would watch those babies for the higher levels of bilirubin. So basically, babies are born, they need to break down the red blood cells. The byproduct is bilirubin. They need to get rid of that through stools. We know that 60 to 80% of the babies will have bilirubin. So we make sure that mom breastfeeds in the first hour of life, baby's getting adequate nutrition. We monitor the stools, and we screen them at 24 hours with a transcutaneous bilirubin level. If that's elevated, then we will do a serum. If the serum is high, the treatment is phototherapy. So basically, it's light treatment to eliminate bilirubin in the blood. What happens is the skin and blood absorb the light rays, and they actually change the bilirubin into products that can easily pass through their system. When we put them under the lights, eye protection is needed. This would be under the lights. Though we can bring the lights into the room with our patients. Sometimes we use a blanket that we put over the baby that still is giving them the light that's needed to get rid of that extra bilirubin. Sometimes babies are even sent home with a bilirubin blanket. The important thing is to keep mom and baby together. There's no reason to separate them due to the jaundice unless there's other ongoing conditions. So their hyperbilirubinemia, again, is in 60% of newborns, 80% of those with preemies, which is a high incidence. It's important to be on the lookout for them. Again, it's due to the breakup of the red blood cells that were needed in utero that are no longer needed outside. The breakdown is bilirubin. The liver needs to conjugate them, but the baby excretes them through the stools. We can prevent by early breastfeeding. We watch out for it at 24 hours. We do the transcutaneous levels. If they're elevated, then we do the serum. We take a little poke from the heel of the baby, send it to lab. If it's elevated, sometimes they need phototherapy. And if the baby needs phototherapy, we monitor temperature, stools, voids, and we need eye protection. When a baby is under the lights, usually they're just under the diaper. They just have a diaper so that the skin can absorb the light rays. Changes in the skin. This baby, you can see, has a little bit of blueness to the hands and to the feet. That's called acrocyanosis. That's a normal finding in the first 24 hours of life. Otherwise, this baby looks beautiful. It's got good tone. It's got good flexion. It's got good color. You can see the eyes appear a little bit shiny, because when a baby is born, there's 3 medications that we actually give the baby at birth. Usually after the first hour of life, after a mom is breastfed and bonded with the baby, we put erythromycin in the eyes, and that's pretty much all babies. Because there are some STIs, when we talk to patients, of course, we just say infections that can actually blind the baby. Gonorrhea, if it's present in the mom during delivery, it can actually cause blindness. And so to prevent any kind of bad outcomes on the baby, we automatically will place erythromycin in the eyes about 1 hour after birth. If you were in the clinical area, you would be able to give the erythromycin in the eyes. The other medication that we give is vitamin K. And again, we'll give that in the first hour or 2 of life. Vitamin K is a blood clotting product. And interesting enough, babies are born with very little. And the reason being is for your body to make vitamin K, you need bacteria in the gut. A baby is born with a sterile gut, and it takes about 7 days to get that bacteria needed to make the vitamin K. So prophylactically, we would give all babies vitamin K to prevent, so that the baby can clot blood if needed. Now, the interesting thing is a lot of people they're against vaccinations and vitamin K, and of course the patients can always refuse. But we have to alert them to what might happen if they don't give their baby vitamin K. And there was a recent study that there was moms now opting out of the vitamin K, and we've had an increased incidence of intracranial bleeds with babies. Also, some babies are circumcised in the first couple of days of life, and if that might be a consideration for that baby. It doesn't hurt a baby at all. It's just vitamin K. It's an IM injection, and we give that again for blood clotting factors, the vitamin K, which the baby is born without because the body needs bacteria in the gut to make vitamin K, and the baby is born with a sterile gut. The last medication we would give prior to the baby being discharged is their first hepatitis B vaccination, and parents would need to fill out a permission for us to give that hepatitis B in the hospital. So those are the 3 medications that are given to the baby. You've got erythromycin, which you can see in the eyes on this newborn, vitamin K, IM, and Hep B, IM. Again, you'll notice on this baby, it's got the cord clamp that would be removed prior to discharge. It also has a bracelet on its right ankle, or it looks like it might be, looks like an ID bracelet. Babies usually are born and they get 3 bracelets. They get a bracelet right at birth that identifies them with their mother and support person, but basically their mother in the hospital. It will match. It doesn't, it will match. It just says like girl, what the time is, but it matches mom. So we make 3 bands, 1 for baby, 2 for baby actually, with that band. And we give 1 band to mom, 1 to baby, and 1 to the support person. And that support person allows that parent to go into the nursery if needed. The other one would be the ID band. And we also put a security on the baby as well. And I think a future picture will show that. Another thing we watch for is RH incompatibility. And I'm not sure how many of you know what your blood type is, but probably after listening to this, you'd probably be interested to know if you are RH negative. If you are RH negative, you're not going to have any problem if your baby is also RH negative. So you could be A negative, O negative, B negative, whatever. But if you are an RH negative mom, we as healthcare professionals will be watching out. We will test the baby once it's born to see what its blood type is. If it's RH negative, it's no problem, but we won't know until after the birth. So therefore, if you are RH negative, during your pregnancy, you'll be tested for antibodies. Now, what happens if you're Rh negative? Let's say you're a first-time mom and you deliver a baby, and that baby is Rh positive. What happens if you do not get RhoGAM is right after that delivery, when your blood will mix with the baby's, then your body responds and say, what is this? And what it does is it makes antibodies against that Rh positive. So what happens in the next pregnancy, if you get pregnant and your baby is Rh positive, your body has these antibodies that will go and attack the red blood cells on the baby, which causes fetal anemia. And remember that weird sinusoidal pattern that we saw due to fetal anemia? You would get that. But many babies do not survive even past 20 weeks. Their losses early on, or they could be lost. The baby can be lost during the pregnancy, even after 20 weeks. And sometimes they're born with severe anemia, and that means that they come out pale, needing blood transfusions. And a lot of times they don't make it. So with an Rh negative mom, she can be Rh negative. The first baby is Rh positive. That baby is born fine. And if we look back in history, sometimes we'll read about women who have one baby and then they have several miscarriages after. Who knows? Maybe they could have been Rh negative and their baby, they didn't survive past 20 weeks and they lost those babies. In 1968, though, they came up with RhoGAM. And what RhoGAM does is it prevents mom from forming those antibodies against the Rh positive fetus. So therefore, what we can do to prevent this from happening is, whenever a woman is pregnant, if she is Rh negative, and that's why we get her blood type in prenatal care, if she is Rh negative, we will automatically at 28 weeks give her RhoGAM. And that will prevent her from making any antibodies. We also give another shot within 72 hours of RhoGAM after delivery if the baby is Rh positive. If the baby is born Rh negative, she does not need the RhoGAM, just during the pregnancy. And usually if the father is Rh negative, the baby might be as well, but we would still give the RhoGAM because we really don't know who the father is. So that's extenuating circumstances. That RhoGAM is very important so that the baby, for the mom, does not make the antibodies that will attack the next baby. Interesting enough, there's other times, though, sometimes that the blood can mix with the baby when you're pregnant. And that could be if you get an amniocentesis, or maybe you're in a motor vehicle accident and there's some leakage of blood that gets into the mom's blood system. Therefore, if you're going to go through any of those procedures or the external cephalic version, when they actually turn the baby from a breech to a vertex, there's a chance that maybe the cord might bleed. We automatically will give mom another shot of RhoGAM to prevent any kind of antibodies being formed. Now, also, usually the antibodies are formed when the baby is born and the blood mixes with mom. But think about this. Think about if there was a miscarriage or termination. Same thing that will happen right after that birth, because that is the birth of a fetus. So therefore, anytime a patient who is Rh negative has a miscarriage or an abortion termination, they would need a RhoGAM shot. True story, not too long ago, I have a friend who's been an OB nurse forever. She has two daughters. One of her daughter got married and moved to Minnesota. She had a miscarriage. And it was very sad for her. And then she got pregnant again. When she got pregnant, they checked for antibodies and realized that she was Rh negative with positive antibodies, and they were high. The person, when she had a miscarriage, her OB doctor did not give her the RhoGAM, and she did not know that she needed it. Therefore, the baby had severe fetal anemia. It was under 20 weeks. She came actually to Arizona to Banner Good Samaritan up in Phoenix, where her mother worked. And there's sometimes what we can do to save those babies is the doctor will actually go through the abdomen or the cervix and go into the vein and take a blood sample and actually give a little bit of a blood transfusion, depending on what that blood sample shows as far as anemia goes. The thing is that the blood vessels are so small, you have to wait until the baby's at least like 18 weeks. By the time the baby came and had that done, the baby was already pretty sick and did not survive the procedure. She was devastated. She lost her baby then, and she knew that any other pregnancy would be extremely high risk and the same thing could happen. all because she did not get her RhoGAM after a miscarriage. And that's what we worry about with moms after terminations or any kind of miscarriage. They need to see their healthcare provider to determine, a lot of things, but one of them is to determine if they need that RhoGAM shot. So again, to prevent the antibodies to be formed after the baby's blood mixes with the mom, which is usually after delivery, whether it's a miscarriage or termination, mom needs RhoGAM. We give it prophylactically at 28 weeks in pregnancy, and we also give another shot after delivery within 72 hours, only if the baby is also RH, if the baby is RH positive. If both mom and baby are RH negative, the mom does not need RhoGAM. So if the mom is RH negative, we will draw, when the baby is born, we get a cord blood sample of the blood. We determine what the blood type is on the baby. If it's positive, mom will get RhoGAM. If it's negative, she does not need it. These are only for RH negative moms. It has nothing to do if you are RH positive. It doesn't matter if the baby is negative or positive. It is only for those that are RH negative. Therefore, you're going to notice on the S bars, it's really important to know what the blood type is on mom and to act appropriately. If that mom is RH negative when the baby is born, once that sample is determined on baby's blood type, if baby is positive, that mom will get RhoGAM. And think that was in the 1960s when RhoGAM came. Think of all the women that suffered losses prior to that. So here it is. If a mother, it can occur if a mother is RH negative and the fetus is positive. If the baby is RH positive, blood enters the mother's circulation. Her body perceives this as a foreign blood type. It's harmful, and she creates the RH positive antibodies in response. The babies, actually what happens is if the baby does have RH positive blood and mom has those antibodies, it attacks the developing fetus, causing hemolysis, which is the breakdown of the red blood cells, also known as erythroblastosis. And how we could prevent that is giving mom RhoGAM, 300 micrograms IM, prophylactically at 28 weeks gestation, and again, within 72 hours of childbirth. The second dose is only given if the baby is RH positive. RhoGAM is also given after abortion, miscarriage, ectopic pregnancy, amniocentesis, and any case in which blood could exchange, causing the mom to form antibodies. RhoGAM is given with each pregnancy, even though she received it in the first. And here's just a picture of mom forming antibodies against the baby. Severe RH incompatibility results in the marked fetal anemia because the erythrocytes are destroyed by the RH positive antibodies. If the baby is compromised, it can actually end in a miscarriage. Some of the things that we can do if mom already has those antibodies, like my friend's daughter, once you have them, to this day, we can't get rid of them. They're trying to do studies in which we can, but to this day, once those antibodies are there, they are there. So they've come up with a treatment where they can actually do a percutaneous umbilical blood sampling and also, if needed, an intrauterine transfusion. So what they do is they insert a needle through the mother's abdominal wall and into the uterus, and they draw blood from the umbilical vein where the umbilical cord is inserted into the placenta. They look at it, and if needed, they can actually give a blood transfusion through that. There's for the transfusion. And here's what it looks like. A needle is gone in. They can draw, they can see what the how anemic the baby is, and if needed, they can actually give a small blood transfusion to help the baby. And because the vein in the umbilical cord is so fragile in early pregnancy, usually the test will be performed after 18 weeks gestation. In my friend's case, the baby was already severely anemic and didn't survive the procedure. Prevention, RhoGAM at 28 weeks gestation, and it will be repeated again within 72 hours after birth if the baby is RH positive. Torch is an occurrence of certain maternal infections that occur early during pregnancy that are known to be associated with various congenital malformations and disorders. So a lot of times we'll do a torch screen on mom, and it's just making sure that everything's okay. The T is for toxoplasmosis, and that's what you find in cat litter. And we know that it can cause extreme abnormalities on the fetus. Therefore, in prenatal care, we encourage all our moms not to change cat litter if at all possible, to have the partner do that or somebody else. And if they do, they need to wear gloves and take extreme caution. O is for those infections that can cause bad abnormalities on babies, and those others are mostly the STIs. Gonorrhea can cause blindness. You've got syphilis. You've got all those. And so when a mom comes in for prenatal care, we screen her for every STI, including HIV. I've had some moms find out that they had HIV when they got pregnant because of the screening that we did. Very sad. But yeah, so we test them for all the STIs. R is for rubella. We see if they've rubella immune. If they're not, prior to discharge, we would give them a rubella shot. Remember, rubella, you guys have all been vaccinated for it, most likely. It was invented in 1968. Prior to that, rubella caused a lot of bad abnormalities on our fetuses, congenital abnormalities, and sometimes even death to those babies. So it's real important that our moms are immune to it. We cannot give the vaccination during pregnancy because it's a live virus. Therefore, prior to discharge from the postpartum area, if their labs show that they're rubella non-immune, they will be receiving rubella shot. C is for cytomegalovirus. Interesting enough, a lot of you probably have had it and didn't know. It's a virus that looks very common to the common cold. A lot of children have it, and it just appears to be a cold and causes no problem. But if a woman gets it and she's pregnant, it can cause congenital anomalies on the baby. So how do we prevent that? Particularly, I'm concerned with the moms that are school teachers and they're with young children. We encourage hand washing and good hygiene practices to prevent that transmission to the baby. H is for herpes, which is we test all our moms to see if they have genital herpes. If they do have genital herpes, a lot of times, prophylactically, what we'll do, if they have a sore at the time of birth, that would require a C-section. And so now when I was first started out as a nurse, anybody with a history of herpes, we had to check them for lesions. We still would, and most women know when they're getting one. It's kind of like a cold sore. You can feel it coming on. But now prophylactically, what we do is we put them in cyclovir at 36 weeks gestation, not prior to that because we don't know the effects on the baby, but at 36 weeks, it seems that when the baby's almost due, we put them on that to prevent them from getting sores so they can deliver a vaginal delivery without any complications. If there is a sore present of herpes, then of course a C-section would be needed, but the cyclovir at 36 weeks is a good prevention for that. So that covers the torch. Again, we talked about acrocyanosis being normal within the first 24 hours of life. And it's just the bluish discoloration of the hands and feet. Vernix on baby is this white, fatty substance of cheesy consistency covering the infant's skin throughout the pregnancy. And basically, the baby is in water, so it protects the skin and it keeps it lubricant. And sometimes if babies are born a little early, they have Vernix because the Vernix begins to fall off in the last 2 weeks of pregnancy. This baby, you can see, is covered with Vernix. It's probably a week or two early. It's not bad. A lot of times we don't rub it off. We rub it into the baby because it's so good for the skin. Caput is just the cone head. The baby kind of molds into the shape of the mom's birth canal to get out. So it comes up with the cone head. Moms are like, oh my gosh, will my baby look like this forever? And you'll say within the next couple of days, that head will round off. But it's a normal finding for a vaginal delivery. C-section babies usually don't get that caput. So caput is just swelling of the tissue of the presenting part of the fetal head caused by pressure during labor. Cephalohematoma is a little bit different. It's an abnormal finding. It's a lump on one side of the head, usually accompanied with bruising. Most of the time it's caused by if we use that suction, the vacuum suction on a delivery. Again, if it has increased bleeding, we watch out, and it's also going to be more prone if there's bruising involved with that to jaundice because of the bruising. So a cephalohematoma is blood from ruptured blood vessels between the skull bone and its external covering, and it's limited by the margins of the cranial bone affected. Therefore, you'll only find that lump on one side. That's the good giveaway. We'll see some pictures here. Milia is these, it looks like little whiteheads on the baby's nose. A lot of women want to pick them off, and you would say, no, that's normal. They'll go away in just a few days. It's just milia. Sometimes babies are born with stork bites on their forehead, on the nape of the neck. Those sometimes take a bit of a time, but eventually they will fade. Some adults, when they get mad or they laugh really hard, you can see that redness appear from where they had that stork bite, but it should disappear. It just takes a while, and sometimes it's frightening to parents to see that. You can have it's interesting. You can have the most beautiful newborn baby, but if somebody walks in and see the stork bite, that's all they see. That's just kind of human nature. But yeah, it should fade. Erythrotoxicum is just a newborn rash that occurs usually once the baby is discharged home. It's a normal finding. It'll go away after a couple days, although a lot of times parents are ordering photographers to come to the house and take pictures of the baby. They may want to reschedule if the baby comes up with their erythrotoxicum, meaning newborn acne. It'll go away and it's fine. Mongolian spots are these dark bluish spots that appear on the buttocks. Moms will go, "What happened to my baby? Did you spank it?" You will say, "No, it's normal finding," particularly those that have dark complexions, African Americans, Hispanics, Asian people. You'll see them and they're normal. They'll also fade in time. In the reproductive system, it's normal for little girls to come out with a swollen perineum and a little bit of vaginal discharge due to mom's hormones. Males can come out with a swollen scrotum as well. Sometimes the testes are not distended, so we check to make sure that they are in our newborn assessments. Breast tissue, they can be swollen both on male and females at birth, and that's due to mom's hormones. And sometimes the girls have a pseudomenstruation due to mom's hormones. All those are normal findings, and you just would, as you do your assessment, you would also educate the parents on that. The head looks out of proportion to the rest of the body. It's 1/4 of the total body length. There's going to be rapid development in that first year. Remember, the head will mold with labor. Limbs should be symmetrical. We check for any dimple or for signs of spina bifida. And sometimes we do the Ortolani maneuver to check for hip dysplasia. In some hospitals, it's only the healthcare provider. They bring up the knees and they open up. If there's a click, it could mean hip dysplasia. Again, in some hospitals, the healthcare provider, not the nurse, does those. Neuromuscular, the neuromuscular system is pretty, it's developed at birth, but it's still evolving. Some babies look like they're like having little seizures, but it's little tremors. It's pretty normal. And as the nervous system matures, those will go away. It's normal for a baby to sleep about 17 hours a day, which is important for moms to get their sleep. Not all babies do that. Babies are born with reflexes that we look for. They're born with the ability to suck and root. And root means when you touch their cheek, they're looking for nipple or looking for food. It's natural search for food. They're born with the ability to swallow, to grasp grasp a finger, and the extrusion of the tongue. And I think I have some pictures on another slide. Here's the rooting. If you touch that cheek, the head's going to turn looking for food. That's why sometimes when you hold a newborn baby, they'll start looking for food, and people will say, oh, baby's looking for food. Give it to mama. She's the one with the food if she's breastfeeding. The Moro reflex is a startled reflex, and I think I have a better picture on that one. The tonic reflex is if you turn the head to one side, notice how the arm and the leg extend, and on the other side it flexes. That's called the tonic or fencing reflex. When we do a newborn assessment, we do all these reflexes. A Babinski is when you get this, if you touch even with your finger and you go on the outside of the foot and then under the toes will fan. Interesting, in an adult, they do not, but in a baby, they should fan out. That's the Babinski reflex. And if you put your finger under a baby's toes, they're going to grasp. That's the plantar. They'll grasp. I love that one. Where the little toes hug your finger. Here's a great picture of the tonic or the fencing. The head is turned to the right, and the baby automatically extends that arm out to the right. Little boys and circumcision. Interesting enough, it's considered cosmetic surgery, so they're not recommended by the Arizona Pediatric Association. Basically, what circumcision is, it's the removal of the foreskin from the glands. Basically, it's a decision by the parents, but since it's considered cosmetic, then sometimes insurance companies will not cover it. Some cases they will. There are benefits and there's risks to the circumcision. Some of the benefits include a reduction in the urinary tract infections on the little boys, also penile cancer and STIs later on in life. I've known some people that have not circumcised their babies as babies, but then they kept having infections and they had to circumcise them later on. That's something to consider. Some of the risks of a circumcision right after birth include cold stress, some bleeding, infection, hypoglycemia, aspiration, and trauma to the penis. I would say that most circumcisions that I see now, the thing that the babies don't like is they're strapped to this like tray, but then the doctors normally will numb the penis, and we give babies a little bit of sugar water on a pacifier. And interesting enough, I've seen babies just kind of suck away during the circumcision, not bothered at all by it. So they do use some analgesia for that. Looks pretty traumatic though. There's different methods of removing that foreskin as well. Care for circumcision afterwards is when the baby comes back to mom. Usually we encourage bonding and breastfeeding. We do put Vaseline or petroleum jelly on the tip of the penis to promote healing, but also so the diaper does not stick to the penis. We wash it with just very simple water and soap. Nothing more is needed for the healing process, and sometimes it gets this exudate with this yellow, like look at scabs. We tell parents that's a normal healing and not to pick that off, and that's normal. We also encourage them to check for redness and swelling and other abnormal signs of infection, but most babies do quite well with circumcision, and all that's needed is a little bit of Vaseline to prevent the diaper from sticking. After birth, we promote bonding in that first hour. But we also, within the first couple of hours, we're going to weigh the baby. We're going to get a head circumference, which is the HC. We're going to measure the length of the chest circumference as well. We'll do a skin assessment. We'll do a head to toe assessment. We'll do vital signs. We'll give the medications, the vitamin K, the erythromycin, and the Hep B. We check the cord, and there should be 3 little holes. There should be 2 arteries and 1 vein. Sometimes our babies have a 2-vessel cord, and sometimes they're a little scrawny, but sometimes the babies do just fine. We get footprints, and a lot of times we give a set to the parents so that they can have that memorabilia. On a head-to-toe assessment, we just start at the top of the head. We look for the fontanelles, which is the anterior and the posterior. We check to make sure that there's symmetry with the face features. We check the nasal nares to make sure they're patent. We check for a sucking reflex by putting our thumb on the top of the roof of the mouth to make sure the baby is sucking. We could check for crepitus at the shoulders, which may indicate that there may be a broken clavicle. Sometimes there's a baby gets a broken clavicle if it was a large shoulder for delivery. And usually what happens, we'll feel crepitus in the shoulders, but we'll also see that arm is hanging. It's not really moving. Most of those heal without incidents, but we would notify the healthcare provider on that as well. We also check the abdomen. We check for heart rate, respirations. Normal heart rate is 110 to 160s. Normal respirations is 30 to 60. And then we check a temp, which a normal temp would be 97.5 to 98.5 is normal. Every facility is a little bit differently on that. And so there's a lot that needs to be done on that newborn, a lot of assessments. We check all the reflexes, the sucking, the rooting, and the plantar grasp, and all those we check, and we make sure the baby has them, and we do have to chart that full assessment from head to toe. We check for the Babinski, we check the testes, we check for swelling, we check for the dimple, head to toe, full assessment. Some hospitals will do a security photo. We put a security device on the babies. We use the bulb syringe if needed. If baby's having a hard time and has a lot of secretions in the mouth, we would use that. We help mom with feedings. We do the diagnostic tests. One of those would be for the bilirubin. We also do a newborn screening test where we're state mandated. We're testing for like 30 things like PKU, galactosemia, and after the baby is 24 hours, we poke the heel for that particular screening. We also do a hearing screening on the baby before it's discharged to make sure that we're screening those to make sure that if they need further follow-up. That newborn screening, the test for PKU, galactosemia, again, it's a screening so that we can have early identifications of some genetic disorders that may occur. All right. If you have any questions, we'll have more discussions and a little bit more activities on the newborn.